the ear without any trauma being caused to the patient. So at this stage, I just reassured the patient and we had a chat for a couple of minutes. And the reason why this patient was completely terrified was a couple of months ago, this patient reported a blocked left ear and they went to see someone to have this removed. I'm not going to name or shame any company or individual. And the person wasn't able to remove the blockage and asked the patient to use some drops for 7 weeks. And the patient did as they were told. So during this time, they weren't able to, of course, wear their hearing aids because they were using drops and the ear was blocked. A month later, I think it was a few weeks later actually, but between 2 and 3, they had another unsuccessful attempt of removing this. But unfortunately, during that procedure, this patient experienced extreme discomfort because the specialist was poking and prodding in the ear, as the patient describes, and it really left the patient traumatized. They were so anxious about having their ears cleaned. They know who I am and they've been watching my videos, so they felt somewhat reassured because they've seen so many cases. But this patient was told, they still weren't able to hear, of course, obviously after the last appointment, but they were told that their eardrum was completely visible and there was just some wax around the edge. Now, first of all, you can see this is not wax. Again, the patient just jumped there. They were really on edge here. So again, just reassure the patient, because we're going deep into the ear, they could hear that increased noise level and they were getting worried that we may cause some trauma. So this is what a bad experience can do to a patient, and quite understandably so. The patient was elated after leaving. Now, so this patient, as you can clearly see, has got a fungal infection. I would say it's a mixture of candida, because it's quite a thick, creamy discharge that's coating the eardrum as well. Quite often with fungal infections, they can manifest deeper into the ear where it's a bit warmer and more humid and moist. And there's of course some evidence of fungal spores, so there may be another strain involved here, like Aspergillus niger, for example. So, but this patient wasn't aware that they had an ear infection. They were blissfully unaware, they weren't told this, and they only just saw this, the other person a few days ago. Now, is it possible that this all occurred since? You can't say no, it's possible, but is it probable? No, I wouldn't have thought so. And quite clearly, this patient's eardrum was not visible because I've just removed a thick, creamy layer of discharge off the posterior aspect. Now, guys, I'm not going to be able to remove every little aspect. It's just not possible. One, because even if the patient was extremely calm and cooperative, even then it's just not possible. But of course, because this patient's on edge already, it's near impossible. I'm just trying to remove as much of this discharge, this thick, creamy otomycosis and candida, possible Aspergillus fungal strains off the eardrum and around the ear canal. And that's to allow this patient to then obtain the appropriate medication. I have written to the GP and requested an ear swab just in case. We don't, well, I'm pretty sure it's a fungal infection. I'm sure many of you watching this now will be able to identify it more so than this other individual. I just don't want to take any chances, so requesting an ear swab. In the meantime, they have got some antifungal solution drops over the counter. And the reason why I'm quite annoyed, because this is becoming forever more frequent now, not just with myself, but with other specialists I'm speaking to. I probably won't be the one who catches a lot of these cases, because I'm not going to lie, I'm a lot more expensive than most people, so that will deter a lot of people, and I can understand that. That's totally fine. But of course, because of the complexity of cases I'm now doing, I have to justify that price. So, but I know a lot of my colleagues are experiencing such cases now, and we're all just getting a bit fed up, but more importantly, we're getting concerned for the patient's health and safety. So what can a fungal infection do if it's untreated? Because if this patient just carried on under the pretense that their ears are completely clear and the eardrum was visible, a fungal infection can potentially lead to a perforation of the eardrum. That's because fungal infections can cause thrombosis, so kind of a clotting of the blood vessels, well, in the case of the capillaries, and maybe even penetrate into the periosteum, which supplies the blood supply to the temporal bone. one plausibility. And with any infection, if it's not untreated, it can then potentially lead to necrotizing otitis externa. Typically with necrotizing otitis externa, the main pathogen is a gram-negative bacteria. And what we mean by, you get two types of bacteria. I know I'm swaying away slightly from the topic of this, which is the fungal infection, but you get gram-positive bacteria and you get gram-negative bacteria. Now, the difference between the two is, if I'm correct, the gram-positive bacteria has quite a thick cell membrane, whereas the gram-negative one has a less thick cell membrane, so it's kind of like a one layer of phospholipids, whereas the gram-positive has several layers of phospholipids surrounding the cell membrane. But the gram-negative bacteria is encapsulated by a kind of thick layer of lipids, which makes it more difficult to penetrate. So they are more resistant to antibacterials, and they are more able to mutate and become resistant to antibiotics, and they are more likely to be able to share their DNA with other gram-negative bacteria to become immunized against bacterial treatment, so I should say antibacterial treatment. So necrotizing otitis externa, which is where it's a form of osteomyelitis, and that's where the temporal bone gets infected. And the temporal bone is the bone that encapsulates the ear canal, and on the top section, so where we are now, the bone on top of that forms the skull base. So a necrotizing otitis externa, if undiagnosed and spreads to the skull base, I believe has a 20% mortality rate. So this is no joke when we're dealing with ears. Just this evening had an inquiry from an optician who wants to get trained in ear vac. Can't believe it. So I wasn't aware that being an eye specialist makes you an ear specialist. So I kindly explained to the optician that I'm not suitable. I don't possess the prerequisite skills and knowledge that's required, and this is not a taboo subject. A couple of specialists, colleagues of mine, are actually blaming me. It's all in good jest, really. But they say that when you watch the videos, a lot of people think it's really straightforward to do, and therefore people from all walks of life, clinicians from different specialities, think it's just a straightforward thing. They just watch the videos, not just my videos, but other people's videos as well. We share it online, and it's just so easy. What you're seeing is a magnified view here, guys. The ear canal, this is not straightforward. When we enter the ear, it's bendy and it's twisty. The inner two-thirds in particular is really sensitive. We've got a layer of skin that's 0.1 millimeters in thickness around the bone. We've got the eardrum, which is a similar thickness, so it's easily penetrable. In terms of the diameter of an average ear canal, so the average width is about 0.5 to 0.7. The height between 0.7 and 0.9 millimeters. We can get much smaller ear canals, particularly those that we're performing earwax removal in, because the smaller the ear is, in adults are more likely to get a build-up of earwax. So, and the instruments themselves, they are sharp. The Microsuction probe that I'm using is 2.1 millimeters in diameter. The fine end is about 1.3 millimeter in diameter. So we're having to navigate into really